CU code at the end of this presentation. So before we get started, please remember to mute yourself. Questions can be asked using the chat feature. I will go ahead and turn it over to Anna Sokol, your presenter for this session. Good luck, Anna, and enjoy, you guys.
Thank you, Philip. I am very happy to be presenting at the ISS. This is my first ISS, and I am a nurse. I actually have the kinesiology and nursing background, and I work at Motion Concepts. I joined Motion Concepts about 2 years ago. In my previous work, I was a manager for the community care company where I was overseeing the delivery of care from PSWs, nurses, respiratory therapists, occupational therapists, physiotherapists, speech language pathologists, and social workers. And the care was delivered at home and at retirement residences and long-term care facilities. So bringing some nursing managerial focus to this presentation, today I hope to link two major themes together: the seating for the wheelchair and the outcome measures, or the quality and safety metrics. So I have to start with some disclosures. I am the employee of Motion Concepts, which is the subsidiary of InvaCare, and throughout the presentation I will be using images and pictures which will show our product, and it will be easier for me to explain some important concepts. With respect to the intellectual property, the work that is put into this presentation is of my own, and I will be properly referencing all the materials that is used. So at the end of this presentation, I hope that we will all accomplish understanding of the major quality metrics in the long-term care. And when we say long-term care, I would like you to think a little bit broader than just long-term care facilities. When we say long-term care, we need to understand that throughout the world, we now deliver and receive long-term care, not just at the facilities, but it could be different settings such as homes and group homes. We're also going to be talking about the major features of wheelchair seating design that are desirable for prevention of falls, the features of design aimed to prevent the pressure injuries, and those features of the wheelchair seating design that are aimed to help with infection prevention and control. So I'm going to start from the beginning. What are the major quality requirements for long-term care across the world? If you take a look at the WHO documents and the OECD documents, you will notice that there are very major themes that show up describing the quality metrics in all the countries. There will be falls, pressure injuries, care-related infections, and the preventable hospitalizations. We know that 30 to 50% of people living in long-term care institutions fall every year. That's according to WHO statistics. And we know that the worldwide prevalence of pressure injuries ranges between 11 and 15%, and in facilities up to 32% in some countries. If we take a look at country by country comparison with the question, are quality requirements the same? What do we report? Do we report the same things in different countries? Let's take a look. In the United States, 22% of residents live in skilled nursing facilities, and these are the long-term care facilities that are funded by government. They experience adverse events, and it is estimated that half of these events result in hospitalizations. Unfortunately, it's also estimated that 59% of hospitalizations could have been prevented. So the majority of these hospitalizations, if we go to analyze what do they fall under, there would be either falls, infections, medication management related incidents, or pressure injuries. When we take a look at Canada, in Canada, we report adverse events on a quarterly basis, and that means we also have to track the quality metrics on a monthly and quarterly and yearly basis. We report falls, pressure injuries and hospitalizations to the Ministry of Health. And it is now estimated that about 200,000 Canadians live in long-term care homes in the facilities, and the remainder, they actually receive the care at home. When surveyed, from the statistics of 2 to 5% to 5 to 25% in the facilities, the residents actually fall. And the statistics that is measured in Canada is how many falls happened in the past 30 days. We use the Inter-Eye system. With respect to infections, Public Health Agency of Canada is overseeing the infection prevention and control. And right now, given the pandemic, this is one of the trackable metrics as well. But three major topics and three major metrics that are reportable by each healthcare organization, there will be falls, pressure, injuries, and infections. What do we know about falls with respect to long-term care? This is very much related to our senior statistics. We know that, unfortunately, over 1/3 of seniors, which are individuals 65 years of age or older, they get admitted to long-term care as a result of the fall. And unfortunately, we also know that in Canada, the statistics of falls keeps rising, and the statistics of injuries received from falls and the deaths received from falls also is on the rise. So it is interesting that as much as we are moving now with technology and advances in innovation, we, for some reason, cannot really find out what's going on. Why do we, why are we unable to tackle this statistic? So if we take a look in statistics in New Zealand and the healthcare organization there, it is estimated that 15% of residents receive long-term care services. These are seniors 65 years of age or older, and 30% of population actually receives these long-term care services at home. They also use the Inter-Eye MDS assessments, and the trackable metrics, they range. So latest ones, we know that the majority of metrics that have been tracked in New Zealand are now hospitalizations, pressure, injuries, infections, restraints, and falls. And this is very much reflected in the Inter-Eye assessments that are performed by the coordinators in home care environments. Now, I'm gonna just introduce one last one. In Australia, what's going on there? Australia has the world's highest percentage of older population receiving long-term care institutions, 52%, and the lowest percentage of people receiving long-term care at home, 45%. And there's a long waiting line for approval of home care there. Interestingly, that in Australia, the most reportable and trackable metric used to be the elder abuse and the weight loss. And it's just recently that the expectations have changed. And now pressure, injuries, and the use of physical restraints and weight loss are equally valuable when the organizations have to report these metrics. So let's take a look at the wheelchair system. We now know that the fall prevention is one of the metrics that is trackable. And I would like to share with you one study that is my favorite, which is related to falls. This is the study that took place in British Columbia. And the researchers took a look at what's going on in the hallways and dining rooms of the long-term care facility. One facility was the privately paid one, and the other one was publicly paid one. And there were video recordings. The cameras were established there in the shared spaces. And these recordings were taking place over the time of 1.5 years. So when the results were analyzed, the researchers were able to put together some statistics. So almost 46% of falls were related to the three themes that were related to either sitting down or lowering, being seated or wheeling, or getting up or rising. So somehow related to sitting. The rest of them were related to walking, standing, and sleeping. So when the researchers went further and they started analyzing why people fell down, and the technology now allows us to take a look at the falls and to see what happens a second, 2 seconds, 3 seconds before the fall, they were able to identify major causes of falls. So out of falls that were for people when they were getting up, 40% were associated with the loss of balance, and most often due to incorrect shift of the body weight or excessive sway of the trunk. The falls that were associated with lowering down, they were related with people missing a chair. Either the wheelchair was unlocked, it moved, or they could not establish that final stable posture before being lowered down. For falls that happened while people were sitting on a wheelchair, were wheeling the wheelchair, they were either related to the moving object, most likely people didn't use the seat belts, or they were sliding out of a chair for numerous reasons. So looking at this study, it was actually very informative because at the end, the researchers provided the recommendations. We have to look at the prevention strategies and recognize that we need to implement the strategies for seniors in long-term care that would be related to walking, sitting, and standing, and also have to recognize that we have to pay attention to the design of assistive devices, particularly wheelchairs. Those important transitions, shift of body weight, balance issues, they are major precursors of falls, and we have to actually do something about them. So me being a kinesiologist as a background, I realized that these themes, incorrect shift of body weight, excessive sway of the trunk, failure to establish stable final posture, and loss of balance, I understand that they all related to proprioception. So what is proprioception? Proprioception is our ability to understand where we are in space, where is our body, to understand where we move, to feel the gravity, to understand where we are located in relation to the objects around us. And this proprioception is created as a result of some sensory input coming from multiple places. It comes from sensory nerves, particularly our Vater-Pacini corpuscles and ligaments, from the sensation from the skin, from motor nerves, from visual cortex and vestibular system. So if we go ahead and start digging and trying to understand how can we improve the proprioception, or what are the situations when proprioception is actually worsened, we will find these major factors. The proprioception is worse with aging, we know, because the condition of muscles and nerves changes. We also know that seniors have higher probability of vision loss and some disturbances. Also, interventions in the joints or joint injections, such as steroid injections, for example, they mess up with the sensory input. Neuropathy, prolonged vibration, spatial neglect, particularly for people who had strokes, and low back pain, they all affect how person feels and understanding where they're positioned in the space. So there is a way to improve proprioception, and one of the major ones is improvements in vision. We also know that if our seniors or long-term care residents, they are involved in regular balance training, exercise training, especially when it involves unstable surface, the proprioception will be improved. We now read that short-term therapeutic vibration leads to improvements in proprioception, but also sensation of touching the surface or object. The more input we have, the better it is for our brain to understand where we are. So bilateral 3-4 point surface contact actually improves our understanding where we are. Also, balanced posture of the trunk. So when we know all this, the question may be, how is a wheelchair related to all this knowledge? So if we look separately at the sit to stand transfer, when the person gets prepared to stand up, and we're talking about people who are able to ambulate and able to actually have the transfer, so they may be using the wheelchair intermittently, they use the walker, or they use the wheelchair for some time during the day, and they need to have transitions for the exercise. So with the midline leg positioning, we know that it will allow us to move the center of gravity to where it has to be for preparation to the safe transfer. For the bilateral 3-point support, we need to understand that our hands and legs, they have to touch the surface, and it's good if we have the sensitivity there, or we're dealing with 4 limbs actually being in place. But sometimes this is not the situation. Sometimes it could be a person with amputation. So when we have the highest number of points of surface support or stability, we know that it will improve our proprioception. It will allow us to transfer the weight safely or safer. We also need to understand that the armrests have to be positioned on the proper level in order to be helpful in this situation and in this transfer. And if the wheelchair has the swing away leg rest, it is actually helpful if they are removable, or they could be moved aside so that we remove the obstacle. When we think about midline leg positioning, somebody can ask a question, really, do we need that? There is actually some research available that talks about that sit to stand task is actually risky if the hips are adducted. And by saying adducted, we know that this is where the knees are coming together. It presents the risk of instability, it presents the risk of falls. It is actually the highest challenge for balance control, and females are at higher risk for falls in this scenario, because it turns out that females tend to sit in adducted position more often than men. And if we are adding some coordination challenges with that, when the person has difficulty coordinating simultaneous ankle, lower leg, and hip movements, then we definitely need to aid proprioception. And if we introduce the midline positioning, introducing the cushion that can help with that, we can actually help with reducing the risk of falls. So there is another research that's available that was looking at sit to stand task for people who have visual impairments or spatial neglect. And it was interesting to learn that when we think about sway of shift of body weight, excessive sway of the trunk, lateral, forward, or upright, it's actually more challenging for a person who has visual impairment. And we need to introduce as many proprioceptive opportunities as possible to improve the balance and reduce the risk of falls if the person has the visual impairment that cannot be corrected. So one of the ways that we can do that is introducing the waterfall front edge of the cushion. It, first of all, allows to tuck the feet under, and we can prepare and balance that center of gravity before the person is ready to get up. And for visually impaired people, or for somebody who has diminished sensation, we also know that having that surface contact in the popliteal area, it introduces the wider area of surface contact. It actually aids with proprioception as well. Now, if we look at the stand to sit transfer with waterfall sensation, waterfall edge, offering that surface, the sensation occurs earlier in the popliteal area. And having this cushion with the waterfall edge actually helps to improve proprioception and reduce the risk of falling. Obviously, we would like the person to have a full contact with both feet and both arms if it is possible, and have to make sure that the floor to seat height is appropriate one. But if it's not possible, as a minimum, we always have to remind people to lock the wheelchair, at least lock the wheelchair, it doesn't move. So removing the swing away leg rest is a must. If we have the ability to remove or elevate the armrests, this is helpful as well, particularly for people who can transfer laterally using the board. And I am inviting you to take a look at the wheelchair cushion design and consider it through the lens of prevention of falls. What are the features of the cushion design that could help with balance and improve the postural support and minimize the risk of falling? First of all, the pre-ischial support and rear cushion radius. They actually prevent sliding and the forward migration of pelvis. The adductor and abductor, I already mentioned, they are important in the midline positioning, and they prevent knees from moving medially or laterally, and they allow to prepare for the getting up or sitting down for the person. And if we have challenges with the floor to sit height, having low profile is actually helpful. If the low profile cushion is used, it would actually improve that height and will remove another risk area, the one that gets created with higher seat and that forces the person to slide out. Having a shape of a cushion that is allowing the person stability, it is very helpful, and we always talk about the anatomical shape being the most desirable. There are also possibilities of introducing the anterior wedges. In this situation, this is a Libra that's shown with a possible anterior wedge either bilaterally on one side, particularly for somebody who only needs elevation of one side. It could be an amputated limb, or it could be the stroke resulting in hemiplegia, where one leg has to rest on the foot plate. So having one side elevated may be helpful as well. With respect to center of gravity, we know that for patients in manual chairs, especially, center of gravity should never fall outside the boundaries of the base of support. So it's important to make sure that we have a properly sized wheelchair for each person. But there is also a concept of dynamic stability. There is a stability and lateral stability concept that RESNA manufacturing standards are talking about, lateral stability concept, which means that the cushion will not be tilted. It will not aid in tilting when the person is shifting the center of pressure, center of gravity. So if I'm reaching to the cup on the kitchen, I'm reaching to the fridge, if I have a stable cushion, that means that I will not be falling out. This cushion will not help with losing the balance. It will actually help me with being stable in a wheelchair. It will give me more support. Now let's talk about the different sizes of the wheelchair and different body types. Sometimes we deal with situation where a person's body type could be an apple shape. So we're dealing with narrow hips and wider chest. In this situation, if you have the wheelchair system that allows you to offer the back support that is wider than the base of the wheelchair, it will actually aid in proprioception, and that means that we improve the balance. The opposite situation, when somebody has a pear-shaped figure, when we're dealing with wider hips and narrower chest, can introduce some risk of falling, because this could be a situation that the person will try to lean to one side or another if not supported with a properly sized back. The possibilities where the back model could be fitted to the chest could be narrower compared to the hip width is actually very helpful in this situation. The more proprioceptive feedback we engage in a person using the wheelchair, the more chance for the balance and the lower risk of falls. So I already mentioned about applying locks. Please do not forget to educate the caregivers and healthcare practitioners that we need to apply locks, and no matter how many times we talk about it, unfortunately accidents and incidents still happen. The importance of using anti-tippers and checking position of axles. We already had several sessions today and yesterday talking about this. And sometimes caregivers actually forget to put the armrests back after the side transfer. And I witnessed some incidents that were related to that. Having reminders, props, labels that allow the caregivers to remember would actually help, because the wheelchair user not necessarily may notice that the armrest is missing. So talking about how can we actually prevent the falls in the community, there were some studies and research done that looked at factors and looked at incidents that were occurring. What were the factors that led to the incident on falls? So the factors were broken down into the groups. We know that ill-fitted mobility equipment and delayed and poor identification of risk factors were some that were related to the incidents. And the researchers usually group these factors under the umbrella of OT assessment. But I'm the one that would like to challenge that, because sometimes we don't have OTs visiting our clients as frequently as we would like them to visit the clients. And very often there are other caregivers, nurses, PSWs, that if trained may actually notice that something is wrong with the wheelchair system or wheelchair seating. So in order to activate the OT assessment, it's actually the other healthcare providers that need to notice that something is wrong. We also know that OTs and PTs usually get involved a bit too late sometimes, and there are some gaps that are present in the system where a person could be discharged from the hospital into the community and information may not be transferred on time. Other situations, they may be related to medication errors, some wrong dosages or blood pressure medications or diabetes medications, and they involve primarily doctors and nurses. Individual health and individual behaviors, they are linked to the falls as well, but we are talking about wheelchairs here. So I'm actually very happy to talk about the risk prevention and fall prevention, specifically mentioning the Swiss cheese model of fall prevention. And this is the incident prevention system that's applied to falls, and it was used by the researchers looking at the falls related to wheelchairs. Kendra Batts, she mentioned this one in her session yesterday, and she talked about how by identifying as many risk factors as possible, we can actually prevent the incident from happening. So looking at all the research related to the falls that we have right now, we probably gonna notice one trend. We talk about the poor identification and follow-up of risks related to falls. They could be environmental or functional, but almost nobody talks about equipment. If we include the wheelchairs into the system of risk identification, if we try to look at wheelchairs with some checklists in hand, there is a higher probability of preventing incidents and improving our safety and quality metrics when we provide the care. So ideally, we would like all the lines of defense to be engaged, that we have the most optimal function and health of a wheelchair user, that we have in place the supervision and support and caregivers that are needed, that all the health services are connected, and we timely identify all the risk factors and address them. This would be the ideal world, but we're not there yet. And I would like to encourage you to think about that. I have a very interesting case study, and this is a gentleman that I met in November, which is just 3 months ago now, Mr. Singh. He was admitted to the long-term care facility, and this happened after about 5 months of immobility. It started all from falls. He had 5 unexplained falls that happened throughout the summer. And then he was so fearful of falls, he was so afraid that he stopped getting up from bed, and he spent all the days in bed, and he was refusing to get up even to use the washroom. So he ended up being admitted to the hospital where some medical issues were addressed, but he lost all his muscles and was refusing to eat and developed urinary incontinence. And the doctors and nurses at the hospital actually recommended his admission to the long-term care facility. So interestingly, this is something that has been researched well and studied well, because we know that person who falls develops a fear of falling, and as a result starts moving less, and then develops deconditioning, loses muscles, and then as a result of losing muscles gets to the point of having very poor balance, and then the probability of falling increases exponentially. So this is a situation that was happening with Mr. Singh, but he was very much motivated to regain his mobility status back. And for him, he was lucky. He had a physiotherapist who was the ATP certified prescriber, and he was provided with dynamic tilt chair very quickly, and he was provided with some matrix seating, specifically with the goal of having that waterfall edge and the low profile cushion that would be stable. So in addition to his daily physiotherapy, nurses noticed that he actually was propelling his wheelchair even when it wasn't time for his physiotherapy. So this was caught on camera. So interestingly, that he was so motivated, and he was propelling his chair more frequently than recommended, and he was very eager to learn getting up and walking again. And 5 weeks later, this is the video that the family was able to catch. This was his first smile. So this is a situation that's not typical. We don't usually see this situation happening in long-term care, because primarily we used to seeing person declining, but this is quite the opposite. And I think there are multiple factors that were in place here. So the nurses addressing the medication, the PT and PT assistants working with Mr. Singh, the provider of the wheelchair equipment actually provided the seating and the dynamic tilt chair fairly quickly, within a week. And all of this fell in place, and resulted in Mr. Singh actually getting up and walking again, reducing his pain medications and blood pressure medications. He also reduced his diabetes medications. So sometimes when we think about the prevention of falls and improving the function of the person, it's probably a good idea to think about the wheelchair seating as well. Now let's look at pressure injuries. We know that 50 to 90% of wheelchair users develop at least one pressure injury. And for people with Alzheimer's, cerebral palsy, hemiplegia, paraplegia, quadriplegia, MS, Parkinson, and spina bifida, 82% of pressure injuries develop in the pelvic region. So when we look at the wheelchair statistic, I was actually curious to see what do we know, how many people use wheelchairs, and I was looking at the North American statistics. In Canada, it's estimated that 200,000 manual wheelchair users are there, and 42,000 use the powered wheelchairs. In the United States, it's estimated that 0.6% of population are wheelchair users, and 6% of them use power. So if you calculate these percentages using the latest population estimates of 2020, you get that in the United States, they're close to 2 million manual wheelchair users and close to 120,000 powered wheelchair users. And that means we have to think about the risk factors. We have to think about the factors that we need to address in order to prevent pressure injuries. So there are 5 major ones that we have to think about: pressure, shear, friction, temperature, moisture, and compression. Pressure is the force that occurs at the 90-degree angle. Shear, those acting parallel forces, forces parallel to the skin that distort the muscle and subcutaneous tissues and stretch the tissues near bony prominences. And these are the ones that cause the displacement of internal tissues and can lead to ischemia and pressure injury. The friction is the resistance of the surface when two surfaces rub against each other. Temperature and moisture are those microclimate factors, and we know that the raised temperature locally and the raised humidity locally can actually contribute to tissue being more vulnerable to pressure. And with respect to compression, this is a factor that is often overlooked, but now is finally recognized as one of the important ones as well. We need to try as much as possible to address the postural collapse, because we need to straighten the internal organs so that our lungs and heart can actually do the job. If we have postural collapse, the internal organs could be collapsed as well, and this can contribute to ischemia. So looking at the developments on the pressure injury front, we now know that the definition and the staging of pressure injury has changed, and this was first introduced and proposed by Dr. Sibbald from U of T in 2011. It is now incorporated into the NPIP 2019 guidelines. It is now proposed to look at the pressure injuries from the 2 points of view. Divide them into the superficial skin changes and the deep pressure injury. If you think about it this way, the ones that are superficial skin changes are mostly affected by the moisture and friction. And the ones that are deep, that come from inside out, and those are grade 3, 4, unstageable and suspected deep tissue injuries, they are the ones primarily related to pressure and shear and that tissue deformation. They are full thickness pressure injuries. So what does it mean? What is deep tissue injury? These are the most risky ones that we see as nurses, because on the outside, it can actually look like just a little pink spot, but inside the tissues could be damaged and necrotized and could even involve the bone to the level of osteomyelitis. So this is all caused by the pressure and shear acting deep within the tissues. And these are the ones that we would like to prevent as much as possible. We all very aware about the wheelchair specific factors contributing to the pressure injuries. Ill-fitted equipment, pelvic obliquities, impaired upper body strength or balance, deficits in sensation, inadequate pressure relieving surfaces, impaired upper body strength that doesn't allow the offloading or performance of pressure relief maneuvers. They are all very known, but I often have questions coming from clinicians. They ask me, so if we use the skin protection cushions, are they actually helpful? So in the United States, there is a possibility of looking at cushions and having that category of skin protection cushions. And if we compare whether they're effective or not, we can see that yes, they are indeed very effective. They actually allow us to reduce the incidence of ulcers under the ischial tuberosities and combined incidence of both sacral and IT in pressure injuries. So it's probably worthwhile to look at skin protection cushions. When we look at skin protection cushions, what are the features of the design that we would like to see? So there are three major principles: the immersion, offloading, and envelopment. When we talk about immersion, is the ability to sink into the material. So this ability of the cushion to immerse actually maximizes the surface contact area, and the ability to offload is the ability of the cushion to transfer the forces laterally away from risky ischial tuberosities. When we talk about envelopment, this is the ability of material to conform around the shape. So the fluid sacs, for example, this is in Libra, they could surround completely the bony prominences, and they allow to minimize that shear that can happen with movement or in static. How do we actually distribute the forces? The formula for the pressure is force divided by area. So if you maximize the surface contact area, you're actually reducing the forces acting at any given point. So we can do that by approximating the shape of the cushion to the anatomical contour of the person. So the closer the surface and the contour to the shape of the body, the higher the probability of distributing these forces. In matrix, for example, we using the molded open cell foams when we make the cushions, and this is done by making sure that every size is actually molded, and that size of each cushion goes in 1 inch increment, and it actually matches the anthropometric engineering tables estimations for person size. So looking at the cushion and the design of the cushion, what are the features that can actually prevent the pressure injury? So we know that offloading actually allows us to take the pressure of the risky areas, but how much offloading is sufficient? Between the IT and the trochanter, there is approximate 1.5 to 2 inches of the distance. So if the pelvic seat well is deep enough to provide that depth that allows the elevation and taking the pressure off so that the femurs can actually take on the load. If it has that sufficient depth, it will actually will improve the chances of preventing the pressure injury. Now, is it important for the cushion to support the posture? Yes, it's important. By having the rear cushion radius and pre-ischial support, if we neutralize that position of the pelvis and prevent the posterior pelvic tilt, we actually will reduce the shear forces. So another way of looking at the cushion is probably looking through the lens of, okay, what can I do? Can I actually deepen the pelvic seat well? Can I offload better? And if the cushion has additional supplements, such as additional pads, for example, to elevate under the trochanters, this will give you a better chance to accommodate the person who may be having some dressings underneath. We as nurses can put some dressings on the wounds, and if the person needs some offloading, the additional elevation would definitely help to reduce the pressure. So I shot some video here to show what the material can do when we have this thin viscosity to demonstrate the concept of envelopment. So when the material moves with the person and its thin viscosity, it actually adapts to the shape and movement of the person right in the moment, and it's not delayed. This is how we can actually reduce the shear, and we can protect the tissues. And it's important in both static and dynamic shear management. We can also look at the postures, and we have to think about the postures such as scoliotic, for example, when we deal with obliquities. If we have ability to customize the cushion a little bit and accommodate or work with obliquity and elevate one side or the other, then we have a higher chances of distributing pressure better and minimizing the peak pressures there. And it could be achieved either with wedges or fluid or other materials that are offered in different cushion designs. When we talk about the wheelchairs, it's very important not to forget that there could be some pressure injuries around the ear. And if the person is at high risk of pressure injury around the ear, it's important to have the shape of the headrest actually allowing that protection. So here's the example of the 4-point headrest, Elan headrest, that's available from Motion Concepts, that gives you the clearance of the ear and prevents the pressure being applicable on the cartilage. So I am looking at the time, 5 more minutes, and then we will open up for questions. Infection control. Infection control is one of the reportable metrics in long-term care and in the community. And obviously, over the past 2 years, we heard a lot about this. What do we need to know about the wheelchairs with respect to infection prevention and control? Both routine and contact precautions, they actually require the disinfection of equipment. And related to this would be the requirement of the CDC that the medical equipment and surfaces should be cleaned and disinfected between patients. They should be made of materials that can sustain repetitive use of disinfectants, and they should not have tears, damages, or holes that trap bacteria, meaning that if we have seams that are hermetically welded, this is a better model that will minimize entrapment of foreign material or bacteria inside. There is also now a recognition that medical industry offers some bacteriostatic properties in the materials, and some cushion covers, they can offer the bacteriostatic properties. So as an example, it is great to have an option where you can have slip covers like shower cap style, or you can have the covers that could be reversible. So when you can use them when you need them. So one side is the wipeable and it could be disinfected with hospital grade disinfectants. And the other one could be the fabric side. And one of the options could be the infection control cover that covers the product, the back or the cushion completely and has the zippered option. So looking for products like this will actually help to address prevention of infection, and looking up for products that are compatible with hospital grade disinfectants will just make life a lot easier. That means that will that the staff, the nurses, the PSWs, the OTs, PTs, they will be able to clean and disinfect in just 2-in-1 way, meaning cleaning with the disinfecting wipe and disinfecting with disinfecting wipe. When you work with products, I would highly encourage you to look for the instructions and manuals and see how the products could be cleaned. If they could be put through laundry, it's even easier. And if they could be disinfected, it's actually eases the everyday life. So what I would like to say at the end is that in long-term care, whether we're doing the provision of care in the facility or at home, when we think about the seating products, cushions, the backs, the headrests, and we not only look for the features that will be comfortable for the patient, but will also address the risk factors, there is a chance that we can actually reduce the statistics of falls, and there is a chance that we can minimize the pressure injury prevention statistics, and there is a chance that we can actually reduce the transmission of infections, not just COVID that's been traveling around the world lately, but I'm talking about all those infections that are prevalent in long-term care, such as MRSA, SBL, C. diff, and all those that are antibiotic resistant. Addressing all three, looking at the wheelchair seating with all these factors in mind, has a chance to actually improve our outcome measures. Any questions?
Any questions for Anna, guys? Okay, so Anna, brilliant presentation, a lot of information here, but you were very smooth in giving all this incredible information. So thank you very much for your time. Guys, the CU code that you need to use is HMSMFS, and you can find this code at the text box. Again, Anna, thank you very much for your time. Guys, thank you for spending your time with us, and I'll see you next time.
Thank you.